Hi, everyone, and welcome to this IA 2030 WHO and TechNet 21 webinar series on why gender matters for immunization. This is our third session, and today we will focus on understanding gender-related barriers to immunization, the importance of gender data and analysis. You can listen to this presentation in French. To do so, please select the globe at the bottom of the Zoom window and choose the desired language. I'm going to say that in French for our francophone friends. Vous pouvez écouter cette session en français. Pour ce faire, cliquez sur le globe qui se trouve en bas de votre fenêtre Zoom et choisissez la langue que vous souhaitez écouter. If you struggle to find it, please do let me know in the chat area. Et si vous avez des difficultés à trouver comment accéder à l'interprétation en français, mettez-moi un message dans le chat. Talking about the chat box that I actually just realized that I forgot to activate. Now, it's activated, sorry. You can introduce yourselves and tell us about where you're from, and you can also give us your name. That we would be very happy to know. You can also use this chat box if you have any technical issue, and you can just let me know, and I'm here to help you as much as I can. If you have any question during the presentation, and if you are familiar with TechNet webinars, you know that, please use the Q&A box at any point during the presentation. This Q&A box is available at the bottom of the Zoom window as well. It's written Q&A, and I think in French, QER. So don't hesitate to ask questions at any point, please, and our panelists will answer them after the presentation during the Q&A session. Finally, this session is recorded and we'll share with you the links to the video as well as the slides. We hope that you'll enjoy the session, and I'll give the floor to Stephanie. Stephanie, c'est à toi.
Thank you, Alex, and welcome everybody. As Alex mentioned, this is only our second session, not the third. So don't worry, you haven't missed something. If you were wondering why,
Sorry.
No, it's okay. It just means there's still 3 more to come after this. And so, as you probably all recall, if you're registered for today's session, you will be automatically registered for the upcoming sessions. But just to say that there are still 3 more, so please do continue to share the information with your colleagues, with your network, encourage people to register. Once you're registered, you'll get all the information. As Alex said, the slides and materials will be shared. But if you missed last week and you haven't had a chance yet, you can find the recording of last week's session or 2 weeks ago's session and the materials on our TechNet page. We'll share the link to that in the chat, but it will also be at the very last slide at the end of today. And on that page is where the materials for all of the webinars and the recordings are located. So you can always go back there and listen to anything that you miss. As Alex said, today we are going to be focusing on the importance of gender data and analysis. So in the Why Gender Matters guidance document, which this webinar series is based on, we outline a number of different gender responsive approaches to increasing immunization coverage. And through this webinar series, we're going to be doing a deeper dive into some of these recommended approaches. So today's session will be on the data and analysis piece and why it is important to be collecting and analyzing this data on a country level. And so to take us through this, we have 3 excellent speakers joining us today. We have Michela Manna, who will be kicking us off with an overview on why gender data is important and the reasons we need to be more systematically collecting and analyzing this kind of data in our programs. And then we have Valentina Bigoni, who will take us through some of the analysis that's being done through the Global Polio Eradication Initiative on some of the data that's been collected from the polio campaigns that have been carried out recently. And then finally, we will go to Veronica Kamanga from UNICEF to outline some of the gender analysis work that UNICEF has taken in the regional at the regional level. So over to Michela to begin.
Thank you so much, Stephanie, and hi everyone. and welcome to the second webinar of this series. So as mentioned by Stephanie, I'll guide you through a very short recap on the importance of gender data and analysis, and then we will have these two very interesting presentations, and as mentioned by Stephanie, and then of course questions for time for questions and answers. So as mentioned during the first webinar, we're talking about gender, why gender is important for immunization. Well, gender is a determinant of health and impacts immunization both on the demand side through people's health-seeking behaviors, but also the supply side, so when we provide services. And so if we want to increase immunization coverage, it's really important that we understand and we address all the many ways in which gender interacts with also additional socioeconomic, geographic, and cultural factors. We discussed during the first webinar about gender-related barriers to immunization, both on the demand side and on the supply side. And so if we want to address these barriers, we have to mainstream gender. And how do we do that? We start with gender analysis. Gender analysis is really the starting point of gender mainstreaming. And so how do we conduct a gender analysis? We collect data. We collect quantitative data, but also qualitative data, qualitative information. And so the sum of this information and data help to build up and shape our gender analysis. So when we talk about quantitative data, we refer to gender statistics. So we refer to counts, to percentages, to ratios, gaps, and this statistics is supposed to really reflect the differences and inequalities in the situation of women and men. And it means that we are disaggregating data by sex at a minimum, but also by other characteristics, depending also on the context we are that we want to understand. And gender statistics is really the base then to build gender sensitive indicators. This is a really useful tool when we want to monitor progress against gender equality, but also in our case to measure, for instance, gender barriers. And so here you have an example of data, which is disaggregated by sex. It's the district coverage of DTP3, disaggregated by boys and girls. And you also have an example of an indicators. It's a total number of girls and boys reaching house-to-house vaccination campaign, in this case of polio endemic countries. Then when we talk about qualitative information, we talk about preferences, attitudes, behaviors, and this information is collected through in different ways, for instance, through interviews or focus groups discussion or mapping, workshops, but we can also use existing data. And here you have an example of, for instance, type of question that you can ask when you conduct a gender analysis for an immunization program. Like, for instance, you want to understand how do women and men get information about the vaccines, or you want to understand who makes the decision about the children's immunization in the houses. This is very important information. And here you have another example, for instance, of the barriers to vaccine uptake from the perspective of a community member, but also from the perspective of a health workers. And so to conclude, gender analysis is really essential for our immunization programs. It really helps us to identify, to assess and inform appropriate responses to different needs and barriers. And so it helps to uncover the root causes of gender-based inequities. And so it also provides guidance to adapt our intervention. And the last example here, it's about a situation analysis in Liberia. It's a CAP study. It's a CAP survey where they found out that some of the barriers, one of the barriers was the fact that the mothers could not take their children to the health facilities because they were bringing their children to work. or, for instance, the fact that the distance to the health facility, the facility was too far away and they couldn't afford the cost of transportation. And so what they did is that they implemented a solution, and they implemented after our vaccination drives in marketplaces. So it was easier for parents to vaccinate their children. So you can really see how it is important to understand this barrier and adapt your intervention depending on the barrier that you discover. That would be it from my side. I thank you, and I will hand over now to Valentina Bigoni. Valentina, over to you.
So Valentina, I think you should be able to share your screen now.
I believe so. Well, I hope you can see my screen.
Yeah, you just need to put it in projector mode and then it'll be good.
Excellent. Okay. So let me just add a pointer just in case I need it. Thank you very much. So good morning, good afternoon, good evening, everybody. So I will introduce you to what it has been done in terms of achievements in adding gender lenses into GPI program and its strategy. And I will also show you some results on how this data can be analyzed and looked at for different purposes, including KPIs. So in 2018, the GPI released its gender technical brief. It was an initial gender analysis to understand the gender aspects in polio eradication. It set out the case for 4 gender sensitive indicators. Building on the technical brief and an extensive staff survey and program analysis, the GPI gender strategy was developed and approved by the POB in May in 2019. And then in 2022, a new eradication strategy has been approved and gender has been mainstreamed throughout the entire strategy. The GPI gender equality strategy introduced 4 gender sensitive indicators. The first 3 indicators that you can see actually in the blue box measure access to immunization, while indicator 4 measures provision of immunization. Indicator 1 and 2 serve as proxies for measuring whether girls and boys receive equal immunization coverage. The percentage of male and females with 0 doses, one of the measurement in indicator 2, is a particularly important component because these tell us about missed children and wants to answer the question, are we missing significantly more girls or boys? Indicator 3 is a proxy for the health-seeking behaviors of parents and demonstrates whether there is a bias in the delay of disease notification due to a child's gender. And then indicator 4 measures male and female representation in our frontline workers, including vaccinators and social mobilizers. This is the GPI AFP acid flaccid paralysis dashboard. The analysis is provided by gender lenses, by distribution percentage of boys and girls, the age group, and number of doses received. This is a global data at the country and provincial level, and it is provided to GPI since 2015. Gender has been mainstreamed in the main M&E framework through a 6-month consultative process involving gender and M&E experts at HQ, regional office, and country office level from the whole partnership. Additional gender-specific KPIs and gender metrics have been added. And today we are going to concentrate on the KPI 4.1.3 and its implication on vaccination campaigns and program performance. Here is the introduction of post-campaigns monitoring analysis with gender disaggregated data. Lots of quality assurance sampling, commonly called LQS, is a rapid survey method that assesses evidence of campaign quality following supplementary immunization activities, the so-called SIAs, in predefined areas that normally are called lots, and using a small sample size. So normally in each lot, we have 60 children, distributed in 6 different clusters. And then this assessment wants to answer the most important question, which is the selected child vaccinated? So finger marked. Vaccinated and finger marked means the same. So here, as you can see in the picture, we see a child that has been finger marked. So during this assessment, within the sampling lot of 60 children, we see how many children have the finger mark. And then also other questions about sex of individuals are asked, as well as reasons of non-vaccination. What are the limitations of this analysis? The reasons of non-vaccination aren't included in the analysis yet. It's hard to provide recommendations on corrective actions globally because the analysis should be timely conducted at the country office, considering the context. And then you can do different analyses depending on whether it's for KPIs or for programmatic actions. Here I will present some results on post-campaign quality monitoring for a national immunization day in Cameroon. The SIA took place in May 2022. At the end of each SIA, there are 3 different indicators using 3 monitoring evaluation processes: LQS, independent monitoring, administrative coverage. And then in our analysis, we will be based on the LQS results. LQS for this SIA are overall considered as unsatisfactory. One lot fails when more than 3 children out of the 60 are found unvaccinated, while it passes when 3 or less children are found unvaccinated. So in this case, for this campaign, 51% of the lots failed throughout the national response. At the map at the bottom left, it wants to answer the following question. Out of the sampling lot of 60 children, what is the proportion of girls selected, meaning seen? The green districts are showing where the sampling group was fairly balanced between boys and girls. In pink districts, girls were fairly more than 50% of the sampling group. And then seemingly the blue districts were represented more from boys. This new map at the bottom right, it wants to answer the following question. Out of the children selected and not vaccinated, meaning not finger marked, what is the proportion of girls? In the green districts, not vaccinated children were fairly distributed between boys and girls. In the pink districts, the majority of unvaccinated children were represented by girls, more than 55%. And then the blue districts show where boys were mainly found unvaccinated. And then, we have this map on the top right that wants to answer this question. Out of the boys and girls selected, were they both reaching 90% coverage during LQS? And this question is meant to answer the KPI highlighted in the slide above, and therefore the gender analysis will be focused on results shown in this specific map. So looking at the same SIA, LQS at the provincial level showed that 7 provinces out of 10 failed, meaning not reaching the 90%. Looking at Littoral and West province, they underperformed dramatically. For instance, where like only 10 and 20% of lots passed. The graph on the right shows districts that failed and their results throughout this SIA and the past or subsequent SIAs of 2022 until Q1 of 2023. So we can see where we have only 1 bar, it means that this district has been covered only once since the beginning of 2022. But we can also see that the Bacham district in West province, so they conducted 2 SIAs and only females reached the benchmark of 90% coverage. Overall, in those districts where LQS failed, 73% were failing for both boys and girls. 40% of districts passed only for girls, and 11% of lots, meaning districts, passed only for boys. In terms of KPI, the KPI didn't reach the threshold for this SIA, both for boys and girls. Looking like similarly in another SIA in July last year in Cameroon, so we can see that LQS improved, fairly improved. Now only 37% of the lots failed compared to the 51 of the previous one. We still have to admit that 37% of lots failed is still like quite a worrying, signal for LQS. And despite having more districts passed, still 7 provinces are not reaching the 90% threshold in LQS. However, looking at those districts that failed, so the 71, if we look at the disaggregated data on gender, indicators didn't improve compared to previous SIA. Given the fact that LQS results have been improved, also the KPI, as you can see here, has improved, and both boys and girls achieved the 90% threshold for this SIA. So looking at globally this data for the last 3 SIAs, so we can say overall that passing LQS, regardless gender, remains the main issue in Cameroon. Only 26% of districts always passed for boys and girls. 15% of the districts failed for both boys and girls. Looking at the last SIAs also in LQS, girls have slightly higher chance to be vaccinated. In terms of KPI for the last SIA, both boys and girls reached the 90% benchmark. So to conclude, what is the analysis telling? First of all, where LQS failed, it means that the quality of the vaccination campaign wasn't satisfactory overall, regardless, putting like gender lenses into this analysis. It is important that the sampling group of the 60 children is fairly gender balanced. It is also important to identify geographical pockets where boys and girls are consistently missed. How can we make usage of this information to take corrective actions? And is KPI capable to catch those immunization gaps between boys and girls? And then what are the next steps? The next step would be to include the reasons of non-vaccination, because this can help heavily, to have like a more realistic narrative and to target more the corrective actions. To include gender analysis in a more consistent way while looking at LQS results. We should add also gender lenses into this type of data analysis, also in those areas where LQS passed. And then adding gender analysis using independent monitoring. This would be like another important step to achieve. I thank you very much, and I think I will pass the floor to Stephanie. So I'll stop here.
Thank you, Valentina. Okay, I'm going to share my screen again. Okay, perfect. We should be able to see Veronica's presentation now. Veronica?
Yeah, okay. Thank you, Stephanie. Good morning, good afternoon, good evening, and namaste to everyone. Once again, my name is Veronica Kamanga Njikho. I work with UNICEF as a regional gender advisor for South Asia. So basically, my presentation is to complement what Valentina and Michela made. Probably I'll start from where Valentina stopped in terms of what are the next steps. I think she zeroed in more on the quantitative data, and then her next steps was like, how does quantitative data gives us the next steps in terms of what are some of the reasons for non-vaccination to the targeted population, and how it is important to collect more data analysis with gender lens. So this takes me to the assessment that was conducted in Afghanistan on adopting the gender lens to improve and sustain polio uptake in Afghanistan context. And this assessment was taken just before the new leadership, the de facto authority, took over, but amidst various gender and social barriers to polio vaccine uptake. So the focus of the study, more qualitative, like I said, we were trying to look at identifying what are the pre-existing and emerging gender challenges and other social norms influencing polio vaccine uptake within the context of Afghanistan then and now. I'll explain better later on. And then also looking at internally, as I think Michela mentioned, I think we look at what are the demand side and also the supply side, but we'll also look at the community as well as the upstream, which is a system strengthening. So the study also looked at looking at internal policies, both for the third-party monitors, as well as UNICEF and WHO, who are the program supporter for the polio vaccination within the country, both in terms of procedures to identify challenges and what are the opportunities for women participation at all levels at Afghanistan country office polio program, as well as I mentioned, under the partners implementing the same. And we also looked at the SBC, probably conducting a gender review of communication and SBC materials, because I think too much of it was also to change the mindset, because I think too much of the barrier was around the gender barriers, restricted movement, lack of female social workers, and stuff like that. That was strongest barrier to the uptake. And then the timeline, as I mentioned, it happened around 2020 to 2021, but most of the data collection was before August 2021, before the new leadership, the de facto authority, as we call it, took over. Next slide, please. So as I mentioned, the analysis mostly was literature review and in-depth analysis, both with UNICEF, country office, region office, HQ, and some of the partners, including a focus group discussion, particularly with third-party contractors and the female frontline health workers or polio frontline health workers, and then also a review of SBC UNICEF campaign products and training materials. And then, as I mentioned, we looked at all various levels of the socio-ecological model, from individual, from family, from community, and systems, not only within the health structure, but also with UNICEF structure, to address what are the systemic issues to address the social barriers. And then, as Valentina has mentioned, we also looked at the various framework that were guiding the studies, both the GPEI strategy, the region office, UNICEF Immunization and Gender Guide, and many others, as my colleagues have already alluded to. Next slide. So, as you know, within the Afghanistan context, some of the challenges, we were of the view that most of the focus group discussions would be face-to-face between our consultants, the female frontline workers, the third-party contractors, as well as the beneficiaries. But I think restricted travel for the researchers due to the situation that was there during the data collection, and also the transition of leadership between the former government and the de facto authority, made it difficult for the researchers to be in country. So most of the focus group discussion were done online. And then changes in terms of reference, I think we had also wanted to do safety audits on the policies and the facilities as well as the community, which was also not possible. And then also looking at the context in Afghanistan, we did face some refusal on some of the participants to participate in the study due to restrictions and also the safety concerns around female frontline workers' participation and the whole polio program in Afghanistan. Next. Yeah, so quickly, what are some of the findings? I think, as I mentioned, I'll categorize based on what I had highlighted, where we focus on the FGDs and regional review. First, I think the gender integration in UNICEF and other partners, including WHO, communication and social behavior change and community engagement, whether it facilitated more uptake to polio vaccine. Next, please. Yeah, I think generally the findings, they did allude to the fact that there seemed at that particular time little guidance on how to tailor communication interventions to overcome various cited gender-related barriers to immunization within the Afghanistan context, to dispel misinformation or myths. And as you know, the context of Afghanistan, I think we have very limited female frontline workers, and then access to health facilities is also limited because of the myths, but also the restricted movement for women without a mahram or chaperone, or just the risks associated with moving from a household to a facility, and the whole myths about what a polio vaccine has to do to the health of a child. So I think there was limited information in terms of how do we tailor the language, the communication to dispel all these myths amidst all these challenges that I've talked about. And then generally also what was found out was that there was also some disconnect that was noted between design strategy and available of opportunities for subnational teams to build on lessons learned from gender mainstreaming. I'll give an example that before then it would be, it was house-to-house campaign, going into the households where they would find the mothers with children who are eligible for vaccination, but also with less female frontline workers. How do a male frontline worker within Afghanistan context go to administer vaccine in a household where there's a new mother with a new born child? So how did we tailor the messaging in terms of what is the available strategies, what is available opportunity? And then soon after DFA took leadership, there was kind of a shift in terms of doing the polio vaccine in mosque campaign. So within that communication, how do we tailor our messages, considering that not all women would go to the mosque, and with the restriction of movement and mobility with women to the mosque, what should be the strategies to make sure that we are better able to captivate where the children are, where the women are, considering the context that are there, and also tailoring the messages in terms of where we could find the women, like understanding apart from the facility, apart from their homes, what else are women comfortable to congregate that we can reach them with the polio messages and the vaccine. Next. Yes, so continuing with the same, I think out of the 1767 campaign, specific social mobilizers recruited, like I mentioned, 100% were mostly women. These were frontline workers to disperse the information, to reach to the women, of course, to care other caregivers as men. But if they are 100% men, how sure are we that they are able to reach the women within the context of Afghanistan, which I don't want to repeat again and again. And however, as of December 2021 campaign, more female mobilizers were recruited, but I will also explain after this study what were the strategies that UNICEF and WHO put in place to make sure that we are better able to address the gender barriers. And then the above figures also account solely for the full-time social mobilizers, which at first were 100% men. And then through what I've talked about, we started more increasing on more women frontline workers, including with other social and safety measures. For example, pairing up a husband and a wife, or a brother and a sister, so that the women are able to go out to work, get opportunity to work, but also address this, the protection concerns, but able to reach out to the households of mothers with children, because they cannot go to a facility for vaccination, just like in any other country. Next. Yeah, so some of the highlights, I think this I'll just go quickly, since I've already mentioned that from the SBC and communication engagement, I think two explicitly draw on gender theories and framework. The rest was just Why is it important to have polio vaccine for children without understanding these gender dimensions and the barriers? And then through interviews, it was also evidenced that communities were not included in the design and implementation processes. The women themselves were not, there was no intention of or consciousness to understand what are the needs, how to better reach them, as I mentioned before. And then key informants also highlighted that affected communities or where we have missed communities, they have to be included in decision-making. At that particular time, there was government-controlled areas and the areas which were controlled by Taliban. What were the dynamics that were better able to reach to the women and children in those communities? And then how best to get their voices so that we're better able to have universal coverage to the same. And then also on the intersectoral intervention could present an opportunity for integrated polio into maternal, neonatal, and child health messages which were missed. And then I'll also tell you in terms of, after this finding, what are the other avenues that polio team had to take so that we maximize where to find the women, where to find the children, based on the findings of this research. And then it was also unclear if recommendations from the various previous evaluation were adopted to implement what I'm explaining to you about, because how to, what are the barriers, where to reach the women was not new, but I think we're just unpacking what are the salient or new issues so that we're better able to reach to the missed communities in terms of polio campaign, but also the outreach to make sure that we are better able to maximize the campaign itself. Next, please. So I think another medium was the whole issue of media engagement within the Afghanistan context. And I think maybe I can also go quickly through this. I think this is leveraging on innovation and digital platform. But when you look at during the COVID time, RCCE findings, it was less than 30% of women who are able to access Facebook or any social media, including television platforms, to access messages for immunization. So if a medium of communication, which is through social media and innovation, we did not take a conscious decision on what are the gender barriers or key barriers or percentage of women who are the caregivers to access this information and dispel negative myth. I think this was also one of the problems, but I'll also give you solutions that we started doing post this study. Next. Okay, like I mentioned, this was part of the community mobilization and engagement. And then within Afghanistan context, as I mentioned, I think less than 17% at that particular time were female frontline workers, regardless of polio or nurses or midwives or doctors. And within the Afghanistan context, I think their colleagues have seen from Pakistan and whatever, lack of female frontline workers is a huge barrier to increasing uptake to any maternal and child health, including polio. So we also looked at the whole issue of women participation in polio program, whether the program was also understanding or taking into consideration how to address this barrier. Next slide, please. Yeah, so as I said, I now mixed up the study and also a blend in terms of what is happening. So this is just a snapshot in terms of the polio endemic provinces, and then how we've also seen the increase in terms of female mobilizers, and including the overall female frontline workers across the provinces where we have more polio endemic provinces. But you see that before 2021 August, I think there was a conscious decision from UNICEF, WHO, and our third-party contractors in terms of increase on female frontline workers, including human resource policies and social, protection issues like PSA and maternal health, maternal responsibility, so that we are able to recruit and also retain the female frontline workers. Because in another study, one of the challenges was that because of no lucrative HR policies that would attract pregnant women or women of reproductive age, like maternity leave, breastfeeding corners, this was also a deterring factor from returning female frontline workers. So we saw a sharp increase in terms of recruitment of female frontline workers, but I think this became to a stagnated position after the 2021 August, and I'll explain to that towards the decrease that came by due to the de facto authority. Next. Yeah, so this is basically the numbers of the female frontline workers. I think I've already explained in terms of how we saw the increase because of the strategies and conscious decision around female frontline workers, the social mobilizers, and when there was a mosque-to-mosque mobilization, what could have been the strategies? Maybe we can go to the next slide. Yeah, like I mentioned, I think we also looked at both demand and supply side. And the supply side, we also looked at the systems, not only in terms of the third-party contractors, but also inwardly within UNICEF, since UNICEF is one of the big players alongside WHO. We also looked at what is the leadership commitment towards women's participation and integration within the polio program. And also by that time, I was part of the Afghanistan team. And then we also looked at the whole technical capacity. Do our third-party contractors have the capacity to look at what are the key gender equitable approaches to recruit and retain more women, because the women frontline workers is the whole issue. And then, as I mentioned before, the organizational culture and the environment. Do we have family-friendly policies, not only in UNICEF, but the third-party contractors, the NGOs that we're recruiting to manage the polio vaccine? What kind of support do we need to give them so that we are not only recruiting, but we are able to retain and also enhance capacity of the female frontline workers doing the polio campaign and the vaccine itself? So you see that in 2021, there was an upward shift going up for the leadership as well as for the frontline workers because of the study. And as I mentioned, I'm mixing up with also what we are doing since the study was finalized alongside 2021. Next. Yes, and then I think as I mentioned that the senior UNICEF leadership also confirmed on the need to invest more in financial and human resource. And then I've already mentioned in terms of what is being done, and I'll conclude with what are some of the concrete steps that we applied after the findings of the study. And then women's involvement in the campaign is still low, but I'll also tell you in terms of what is happening and what are the gains. And then in terms of the restriction of movement, without chaperone, women cannot move alone and the man cannot visit the household. I'll also elaborate more in terms of what is being done. Then we can move to the next slide, please. Okay, in terms of external factors, I think I also elaborated more on this. Probably we saw the differences from the map. Women in Kabul, for example, and probably women in Herat or Kandahar, level of education, economic status also had a bearing in terms of how they could come to work, and also acceptance in terms of women or frontline workers coming to their household, or whether to move to a mosque for a house-to-house campaign modality. And then Afghanistan within a facility also adopted segregated facility, workplace at not only at facility level, but also with our third-party contractors. So within our agreement with third-party contractors, we're also blending in terms of how do we comply, whether it has financial implication to make sure that women who are from community are married, they are able to access the workplace through what, whether the former government or de facto authority had put as a precondition on when women are coming to work, where do they sit and where do women sit post-August 21. And then, like I mentioned, I also belabor the point in terms of what are some of the associated risks which women were saying, and we continued post this study to do safety audits in terms of what are the female frontline workers saying, what are the community women saying as the perceived protection risks that are preventing them from accessing the polio messaging and facilities, and what are the mechanisms which I'll elaborate in my last slide in the interest of time. Yeah, maybe we can just go to the next slide. Yet, some of the recommendation to improve on gender mainstreaming in communication, I think there was a conscious decision to continue to build capacity to help not only the third-party contractors, but also the polio staff in terms of how do we apply the gender equitable approaches to SBC, including the service provision. And then also there was a conscious decision from UNICEF perspective, and we're working now jointly with WHO on how do we design messaging at a country level or at regional level that address all these salient issues that are mentioned, the rumors, if the province is mosque to mosque or house to house, what are the messaging that are tailored towards addressing the gender barriers and the myths associated with it, and then continuing collecting of robust qualitative social data. I think as Valentina mentioned, quantitative is equally good as qualitative, so that we are better able to understand what are those social indicators or social barriers or perceived protection issues within the context of Afghanistan that is preventing women to access the polio vaccine for their children, and also for the women to be employed in the third-party contractors and to be retained so that they are better able to access the households. Next, please. Yeah, maybe this we can skip. I think I've already talked to that. Next slide. Next slide. As I mentioned, now we are working together, WHO and UNICEF, to make sure that it's not only at facility level, but also at third-party contractors, what are the family-friendly policies that would retain the women? And then we've also drafted an accountability framework, WHO and UNICEF, with clear indicators on how we assess women's progress, both in participation at all levels, and also how it is impacting on the uptake on the polio vaccine, and then improving knowledge and skills, gender training, not only mainstreaming, but what are those gender equitable approaches to increase vaccine uptake. And also, as I mentioned, leadership both at WHO, UNICEF, and our third-party contractors around the same. Next. We can go to the next. Yeah, I think the interest of time, so that I allow. Next, please. Yeah, so I think the rest are related to the same. I think more strategic focus to implement gender transformative program, what is being done now at a systematic level posts the study that was undertaken. I think the rest of the things I was speaking through it, but some of the issues that could be of interest today. As I mentioned, that we systematically looked at what are the barriers. Barriers is one in female frontline workers, but also the restricted movement from home to the mosque campaign, and the security concerns around within Afghanistan context. So what we did at UNICEF was a gender team to work together with the polio team. We have what we massively scaled within the Afghanistan context post DFA, de facto authority taking over, what we call women and girls friendly safe space. They were initially meant to provide services for gender-based violence survivors or those at risk. But after the findings of this study, because restricted movement was one of the key issues, so we worked together, polio and gender team, on how we leverage on this safe space, because they are within the vicinity of a community owned by the house, donated by an elderly person. So polio started using the safe space. So we saw strengthening of women participation in polio program from 40 to 99 in 2023. And also there was an improvement in gender and security factors, because when Taliban took over, there was most campaign, women cannot go there. But if they were getting this information from the safe space, we saw that this improved in terms of the associated risk of moving from one location to the other. And then there was also polio messaging blended within the gender and gender-based violence interventions, and also mainstreaming or using the Dignity Kit Plus on bringing in messaging of polio within the safe space, where women were coming in on everyday basis, including in provinces like Kandahar, where the restrictions are much more. And then within safe space, I think to attract more women to come, there were all these entrepreneurship programs, soap making and stuff like that, which were attracting women more, and the polio team leveraged on that and also started supporting the polio activities into livelihood activities so that we can better able to attract women. Right now, we're looking at what could be the incentives. If women come to safe space, they're able to get message, they're able to vaccinate their children, what could be an incentive for those particular women? That's another next step. And then also using safe space to build awareness or capacity building on gender and polio within the various, and you can see the numbers. Female mobilizers through the safe space moved from 630, 2023, they are over 800. And then community engagement initiatives, I'll not also belabor much, using the safe space and other platforms. We've increased on community listener platforms through the women and girls friendly spaces and use of radio that are connected to the safe space. This is where women are mostly found. And now we are also looking at what are other pathways that polio team can leverage. Is it a wash? Is it where women are able to draw water from? Is it safe space? Is it where? And now we are coming up into another study of understanding what will women tell us in terms of what are the other pathways that we are better able to reach them. Is it nutrition or routine immunization, wash, or any other that we are better able to catch them? And also we are starting what we are calling listener clubs through the solar radios that will be collective in a safe space so that women can come. If those have security concerns to have a phone, they can come to safe space and leverage on these innovations within the safe space. And then, as I mentioned on evidence, we are coming up with another study to look at what are the gender norms, hearing from the women themselves, to complement the safety audits that the women have been already telling us about, what are the perceived risks that we're continuously able to address through leveraging on safe space and other platforms where women, they are able to tell us that this is where we are comfortable to get the information and to get the messaging. And right now we're discussing how do we incentivize not only frontline workers, but the women who are able to come forward and immunize their children. I think let me stop there for now, and then the rest I can respond through questions. Thank you so much.
Thank you so much, Veronica. That was a lot of information, but really, really rich. And I think that actually some of the questions that we've seen popping up in the Q&A box may actually have been addressed through your presentation. So I hope that for those who have asked some of these questions, they may already have received some of their responses. For example, Ihoma asked, apart from the polio program, what are some of the strategies for other routine immunization vaccines? And I think that, in the last slide that you just showed, all the strategies that have been employed can equally be applied for routine immunization. I mean, polio vaccine is a routine immunization, and there, everything that's applied to the learnings around the delivery of the polio vaccine can certainly be extended to increasing access to all other routine immunizations. And I think that really underscores the importance of doing these types of analyses, finding out exactly what the particular barriers are in the context in which you're working, because like anything else, everything is very, very context specific. And the first step is identifying what the barriers are. And then the second step is, of course, designing interventions to address them. So it all comes down to this importance of having the data in order to actually inform, how we design our programs. Somebody asked, Abdu asked about a set of indicators around gender-related issues. And so this remains a gap for a lot of immunization programs, because this isn't something that's necessarily being systematically collected. Even sex disaggregated data, as really was the focus more of Valentina's presentation, actually looking at the difference in coverage between boys and girls, that's not always systematically collected either. And so it's important to start looking at that. But as we know, and what was more really highlighted in Veronica's delivery, is that it really goes beyond just the sex disaggregated coverage data. The gender related data is more about what these sociocultural factors are around the populations that you're trying to reach and what might actually prevent people from accessing services at all. So, in the example that Michela gave at the very beginning around looking at DTP3 coverage, for example, if you have 74% coverage and 73 is in boys and 75 is in girls, that might not really be a significant difference. And you can say you have equal coverage, but what about the 25% that aren't being reached and why? And when you start looking deeper into, what's behind that, when you break it down and look at, who the communities are that aren't being reached by vaccination services, there are oftentimes a lot of interesting gender-related data behind there. And so just in the interest of time, I want to reiterate, we mentioned this in the last webinar series, but the guidance document, Why Gender Matters, there's an annex, Annex 3. It covers a lot of suggestions of the types of gender-related indicators that you can start to look at in your program, some of which you might already be sitting on interesting data through DHS or mixed surveys that have already been done, health service provision assessments, sometimes routine surveys that are being done in the country have a lot of good quality gender-related data in there that you just might not be, using as a secondary source. And then, of course, also, as Michela mentioned, surveys, CAP studies, workshops, different types of qualitative data collection methods that can draw out a lot of this information to help inform the programs. But for suggestions of indicators to look at, I really encourage everybody to look at this document, particularly Annex 3 has a lot of interesting suggestions in there. I'm just looking if there's any specific questions to our panelists. Armand is asking about whether in for polio campaigns, tally sheets are adapted to collect this sex disaggregation, so girls and boys vaccinated. So maybe Valentina or Michela can answer that question.
Yes, I can answer to this question. No, so the answer is no. For tally sheets, we don't have this information. Also because tally sheets, it's not digitalized information, so it's just the summary of like a daily assessment is put together on a daily basis, but is the summary of many written questionnaires, basically. So the tally sheet is not available in polio, at least. For what is related to SIA data is mainly LQS and independent monitoring, which is already like a quite important information that we have, and it has been unused and unexploited until very recently. So instead of looking for how to get more information, I think the program now should be able to use this data at its best and to use its potential. Over.
Thank you, Valentina. I don't think there are any other open questions. Veronica, did you have anything else to add just to some of the general questions that have been posed, or anything further to add?
I think that's fine. I think in some of the contexts, like within the Afghanistan context, which I would use, as you mentioned, I think we've been moved beyond collecting sex disaggregated data, and then jointly SBC and gender team have been coming out strongly to bring in what are some of the gender related issues that would inform the polio programming, and also picking up what are the key recommendations which would bring to the mainstream Ministry of Health and polio team in terms of what are some of the qualitative indicators that should be mandatory to make sure that we are systematically better able to address these key gender barriers. I think, as you mentioned, I think it's beyond how many girls or how many boys we are reaching, but what are those other factors that are detrimental to their being missed children? So I think much of it, we are also using the qualitative study and using the safety audits that we are doing on a quarterly basis to inform like a pager advocacy that we engage with all the third-party contractors or NASPs in terms of what are some of the critical gender-related indicators that if they are not in the polio IMS, but they inform part of that so that we systematically continue to address these issues. But apart from that, I think this is okay. And I think what is critical, like I mentioned, I think in terms of context, which is emergency related specific, what are those other issues that are not unique to Cameroon probably, or Nigeria probably, or Pakistan, but are unique within the conflict context that we have to take into consideration at a global level as we're implementing the global program to eradicate polio within the context. I think that's all what I could contribute. Yeah.
Thank you, Veronica. So I know we're at time, and that means we're going to be losing our French interpretation. So we need to close. But I also just saw that Allegra put a question in the chat around male engagement and whether there's any work being done around strategies to increase fathers' involvement in decisions. And the answer to that is yes, there's absolutely a lot of work being done in this area in particular. And we have a focus of one of our upcoming webinars specifically around this, bringing more male engagement and family decision-making around health issues. So yeah, please tune in for that webinar. That's in a few weeks' time. Again, all of these materials will be shared with you, and everything is available at the link that's on this slide right now. So you can go back and check anything that you miss. And we really look forward to continuing these discussions with our subsequent sessions. Thank you again to all our presenters today. Thank you again to the audience. Thank you again to our TechNet coordinators for the logistics support. And Alex, anything else to add?
No, thank you. The next session is in 2 weeks. Is that correct? Next week or next week?
Yes, next week. We should point that out. We're accelerating the timelines a bit because we know everyone's going to disappear for summer holidays soon. So yes, please come back next week for the next session. Looking forward to it.
Yeah, thank you. Thank you, everyone.
Thank you.
And have a nice rest of the day. Bye.